Hello, and welcome to Bite-Size MRCP, a manageable way to digest the things that you need to know for your MRCP exam. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organisations, and the materials covered are by no means an exhaustive list of what can come up in your exam, and indeed are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button, which is on sarcoidosis under the section of rheumatology. What is sarcoidosis? It's a multi-systemic granulomatosis disorder with unknown etiology. As for its epidemiology, it affects between 20 to 30 people per 100,000 in the population, and in the UK it's commonest amongst Asian immigrants. As for its signs and symptoms, it really has got quite a heterogeneous presentation, and that's to say that the signs and symptoms can range quite vastly from having no signs or symptoms to acute presentations with erythema nodosum and multi-organ involvement. Just to break it down a bit further for you in terms of the different organs and systems that it could involve, starting with the commonest one, which is the pulmonary system. It can present with dyspnea, fever, cough, fatigue and weight loss. In terms of skin, it can present with erythema nodosum or lupus pernio. In terms of musculoskeletal disorders, it can present quite acutely in the form of bilateral ankle swelling. It can present with lymphadenopathy, splenomegaly, hepatomegaly. In terms of cardiac, it can present with arrhythmias, bundled branch blocks or complete heart blocks. It very frequently causes acute kidney injury if it has got renal involvement. It can present with anterior uveitis in terms of ophthalmological presentations. And in terms of neuropresentations, it can present with cranial nerve palsies and signs and symptoms consistent with space-occupying lesions, so really quite vast. Some of the exam favourites that are not too infrequently examined in MRCP examinations are a couple of syndromes that are associated with sarcoidosis. And the first one being Lofgren syndrome, which is hilar lymphadenopathy, ankle swelling, and erythema nodosum, which is a triad of acute sarcoidosis. And the second one is Hirschsprung-Waldenstrom syndrome, which presents with the acronym PUF, which is parotid gland enlargement, uveitis, facial palsies and fever. So, in terms of the investigations that you want to do for your potential diagnosis of sarcoidosis, after taking a thorough history and examination, you would want to start with bedside observations, and that is to calculate their News score to make sure that they're hemodynamically stable, and also to do a urine dipstick to look for any evidence of hematuria or proteinuria. Then you want to do some blood tests, and that's to look into full blood count to check for any evidence of anemia or infection, renal and liver function testing. You more importantly would want to do a bone profile so you can get your adjusted calcium through that, because very frequently sarcoidosis can lead to hypercalcemia. You also would want to be doing your inflammatory markers such as ESR and CRP, as well as your vitamin D levels. And historically, some of you might remember that serum ACE level were being measured to help with the diagnosis of sarcoidosis. However, it's really important to know that current practice does not focus at all on serum ACE levels, because they are really quite non-specific and they don't have a very good sensitivity for sarcoidosis. After having your blood test, you really want to be getting a chest x-ray, because as we said, pulmonary or lungs are the commonest places to have involvement with sarcoidosis. And it's really quite common for MRCP to just give you the staging of lung involvement and expecting you guys to either know what it is, or after knowing what involvement it is, depending on the staging, to expect you to carry that knowledge to solve some problem with that. So just to summarize, in terms of the staging of pulmonary involvement in sarcoidosis on the chest x-ray, you have 4 stages, starting from stage 0, 1, 2, and 3. So stage 0 is completely normal chest x-ray, so there is no hilar lymphadenopathy. Stage 1, there is bilateral hilar lymphadenopathy. Stage 2, there is bilateral hilar lymphadenopathy with pulmonary infiltrates. And stage 3 is diffuse pulmonary infiltration. The other investigations that you would consider is CT chest, again to look for more details for any potential hilar lymphadenopathy or pulmonary infiltration. You may need a PET scan, however this is quite specialized and there is active research going on at the moment to better understand the utility of it in the case of sarcoidosis. However, ultimately the diagnosis is made based on tissue biopsy, and really you want to be looking and getting that non-caseating granulomas for the case of sarcoidosis. Why is that important, you might ask? And the reason is that the biggest differential diagnosis to exclude in a case of sarcoidosis is actually tuberculosis, which, as you recall, causes caseating granulomas in contrast to non-caseating. As for its treatment, the treatment really depends on which site of body sarcoidosis has affected and whether you've got any biochemical abnormalities or not. If you've got stage 0 or 1 sarcoidosis, they will normally resolve spontaneously. In stage 2 sarcoidosis, you would need to have serial lung function testing. And if your lung function testing is showing progressive deterioration, then you might consider starting the patient on steroids. However, indication for steroid use in sarcoidosis are only a couple. One is hypercalcemia or hypercalciuria despite dietary calcium restrictions. And 2 is if you've got ophthalmological or neurological involvement secondary to your sarcoidosis. Let's do a question. A 20-year-old tourist from India presents to the emergency room with 2-day history of confusion and bilateral erythematous rash over the shins associated with ankle pain. Given the likely diagnosis, which of the following statements is not correct? 1. Tuberculosis must be considered as a differential diagnosis. 2. Serum calcium is likely to be elevated. 3. In the presence of intracranial involvement, treatment with steroid is indicated. 4. The rash on her leg should completely resolve after treatment. 5. PET-CT needs to be considered as part of acute management. So hopefully by reading that scenario, you have gathered that this case is trying to hint you towards a potential diagnosis of sarcoidosis. And hopefully you have gathered that the rash on the leg is erythema nodosum. As you recall, we said that the biggest differential in a case of sarcoidosis is actually tuberculosis. And that's why you really want to get the biopsy to differentiate between non-caseating granulomas in sarcoidosis versus the caseating granulomas in TB. You may also recall that the biggest biochemical abnormality in sarcoidosis is actually elevated serum calcium. And having elevated serum calcium that's not responding to dietary calcium restrictions is actually an indication to treat sarcoidosis with steroids. Option 3 is telling you that in the presence of intracranial involvement, treatment with steroid is indicated, and that is correct. Because, as you recall, ophthalmological and cranial sarcoidosis are 2 of the body parts that very frequently are actually treated actively with corticosteroids. Option 4 is telling you about the fact that erythema nodosum actually does completely resolve after treatment, which is true. And therefore, option 5 is going to be the correct option here, which is the incorrect statement. And that's PET-CT may be considered as part of the acute management, which is incorrect, because PET scanning in sarcoidosis is towards treatment and response to treatment, and it's not something that you would be wanting to look into in more details in terms of acute management of sarcoidosis. Thanks for listening to this episode of BioStar's MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in the future. See you in the next episode.